Thank you so much, Chantry. And thanks for ever who ends up joining us today. I'm Alicia Zbehlik, and I'm one of the rheumatologists here in WVU Morgantown. And I'm going to do kind of a rapid review of some of the findings that we see in rheumatology, um, uh, specifically in the skin. It's a very interesting and broad part of our practice. There is some overlap with some of the other presentations that we've seen in the past, but we will move forward. So, um, and thanks, Chantry, for controlling the slides. I don't have any conflicts. These are the objectives, just to review some of these common skin manifestations. And I've included cases embedded. I didn't get any cases for this particular session, so I've done some brief cases within the content. So the content will probably be a little bit longer, but please feel free to interrupt at any time with questions. And then hopefully at the end, if it stirs up a case that you've had in the past, that would be interesting too. Um, and so some general principles. There are numerous skin findings in rheumatology. We get consulted frequently for rashes, and they can be the earliest signs of rheumatic disease. So it's always important for us to be checking the skin in addition to the joints and other parts of the physical exam. And then thinking about it, think about if you have to describe a rash to someone, now we use a lot of pictures, but just thinking about the morphology of the rash, the distribution on the body. And for us, it's very important whether the rash is photosensitive or not, because that can help us narrow down what the diagnosis is. And often, if it's a rash that people are being referred to, it can be helpful if dermatology sees them first and sometimes gets a biopsy. They're so good with pattern recognition that they don't always need a biopsy for diagnosis, but as a first step, often they can help direct us. And then there's no single workup for rheumatology. And I know over the past few sessions, we've talked a lot about lab workups, and they can be quite extensive, but there's not one recommended one. If anyone's at a loss, a good place to start is always CBC, Comprehensive Metabolic Panel, to check that renal function. Um, look at platelets, look at cell counts, and then inflammatory markers. And elevated inflammatory markers for us are always very helpful to know about. Often symptoms evolve over time, and so rashes wax and wane, and it can be helpful to reassess at different times. And then there's plenty of mimics of different disease processes and of the skin. So, next slide. So case one, this one's kind of a complicated one and one of the more scary ones that we might see, but this is a 35-year-old man, and he was sent to the emergency room with a new onset of hemiplegia. He had a history of diagnosis of lupus, and this was in the distant past, and it's been quiet over the last several years. And lupus can be quite severe in young men. So they often get our attention, even though they're a minority group within lupus. And I'll show pictures of the skin exam. And he had some mitral regurg on his cardiac exam. He had his afebrile, his blood pressure was normal. And a CT scan of the brain showed that he had an infarct. Next slide. And these are some of his labs, mild anemia, mild thrombocytopenia, and ANA as we would expect. For lupus, we expect people to have a positive ANA. It's exceedingly rare to have the ANA negative lupus. And in this case, his C3 and C4, his complements were normal. And often those can be decreased if they're having an active lupus flare. And the APTT was elevated. And these are pictures of the skin findings. So particularly the left lower quadrant there. And you see what almost looks like bruising, but it's purpura in this kind of reticulated pattern that's broken up. And you can see that he's had a hemorrhage. And then the picture in the left upper quadrant is more of a fine lacier pattern that you might see in a less acute setting. And so the most likely cause, if anybody wants to throw it out there, but this is a typical consult that we would get, probably more inpatient. This person is pretty sick. Um, and the answer for this would be C, antiphospholipid. And one of the key findings I wanted to highlight with this is this idea of livido, like racemosa. You don't have to be specific about this, just saying, but livido is an important finding to look at. There can be normal. Some people get patterns of the vasculature when they're cold. Sometimes you see it in babies, and it can be fine and connected. And for some people, it's permanent. It doesn't change a lot. But paying attention to it, especially in the picture we saw on the previous page, it could be a sign of systemic vasculitis, lupus, or cryoglobulins. And so it can be associated with some severe outcomes, and we want to pay attention to it. I have seen it looking more like this picture on this page with in clinic in people with avascular necrosis of the hip, and they did end up having antiphospholipid as well, although not as severe as what this case talked about. So next slide. And this is just a summary of antiphospholipid antibody, which I don't think we had talked about much in the other ones. It clinically, you have to have clinical findings as well as the autoantibodies, which you can test. And the antibodies you need to repeat in 8 to 12 weeks from the time of the initial check to confirm that they're persistently positive. And so things that we can find are CNS or cardiac involvement, the livido, and part of the history is really important is obstetric loss. So often when we see somebody, we don't think about that. But kind of really dialing back in history, people may have had pregnancy losses and it doesn't get pulled out. So that's an important feature, and a history of thrombosis. The labs that would be positive, you can have this prolonged APTT, and a positive lupus anticoagulant that goes along with that. Anticardiolipin antibodies, and you're looking for higher titers of those, usually ones that are just a little bit above the upper limit of normal, are less likely to be significant. And then they can also have a false positive syphilis test or RPR. And we also check the beta-2 glycoprotein antibodies. It's pretty easy, especially with the electronic health record, to accidentally order beta-2 microglobulin, but those are two separate tests. But that is one thing that's easy to do in the medical record. Next slide. And a particularly severe version of this is catastrophic antiphospholipid syndrome. And these folks are very sick and they would have to be transferred for tertiary care. Lots of precipitating factors, and we treat these folks with high dose steroids and usually heparin for anticoagulation. But this is a minority of patients. But if you see people who are decompensating very quickly, it's important to get them in for evaluation. Next slide. So case 2, this is a 27-year-old woman who presents with a 7-month history of a worsening facial rash. And this is a fairly common consult that we see in the ambulatory setting. She doesn't feel like it's itching, but it gets a lot worse in the sun. It gets worse when she drinks alcohol. Her eyes are dry and gritty and sometimes painful. And she doesn't like the way the rash looks. These can be very frustrating for people, and they're red and bumpy, and there's some visible blood vessels. She tried a kind of low potency topical steroid and it made it worse. And we do try to avoid those on the face if possible. And an ANA was checked and it was 1 to 40. So, and this is the picture. This is actually is a case of rosacea, and I probably see more rosacea. It's more common than lupus, and And some of the things that help us distinguish that are the bumps, these visible blood vessels, and importantly, and I'm not able to point it out on the screen, but it's there's no sparing of the nasolabial folds, and that'll be a theme that we talk about in lupus skin. But it's similar to lupus in that people will say it gets worse in the sun and gets worse with alcohol. So often people are searching and they see that, and so it can be a cause of concern for people in that setting. And then often it's treated with topicals or antibiotics. And people can have eye involvement with rosacea, and that's another reason that people sometimes think it's more related to a rheumatologic disease. And these folks can go directly to derm. The positive ANA at 1 to 40, that's a very low level ANA. It's common in the general population. About 40% of the general population have a positive ANA at that level, and they are considered normal. And so normal, healthy people can also have a very low level positive ANA. So the titer for us matters and probably matters more than the pattern does for the ANA. So next slide, please. And I'm just going to compare it to cutaneous lupus. And there's several different versions of cutaneous lupus. And this is an acute version. And this is more of that malar butterfly rash that people get. This is a classic picture from ACR of American College of Rheumatology that's on our boards. So you can see that it's erythematous, and there is some sparing of those the area around the nasal labial folds, and it's a little bit more well demarcated than the rosacea rash was. And so this is a localized version, and it looks pretty symmetric and more even. And then it can be a more generalized rash, and then and can be extremely severe when it covers the entire body, and that is somebody who needs to be seen very urgently and should go to the emergency room because that can be life-threatening. And one of the key takeaways is for most rheumatologic rashes, avoid the sun. And because it can make things worse, it can be a trigger for lupus flares, as well as dermatomyositis. And it can leave hyperpigmentation of the skin, but in general, this version of cutaneous lupus is non-scarring. Next slide, please. And then this is another key finding and is helpful to think about in comparison to dermatomyositis. So this is the articular dermatitis, and also some periungual around the nail folds in terms of the color, the red color there. And so this can be very helpful diagnostically because it's between the joints, and it is not over the joints as it is in dermatomyositis. And we'll look at some of those later on in the presentation. But if you see this rash, definitely think lupus. Next slide, please. Another pretty common version of cutaneous lupus is the subacute cutaneous lupus. And it's got a little bit more of a beefier appearance. It's thicker, it's more hyperkeratotic, so it's got some of that scale and the overgrowth of the upper layer of the skin. Again, it's photosensitive, so people get it in sun-exposed areas. Sometimes in areas that are not sun-exposed as well can be triggered by a severe sun exposure. And again, this tends to be a non-scarring version of a lupus rash, but can leave people with hyper or hypopigmentation, which can be disturbing. And people with this version in particular should be monitored to exclude any progression to systemic lupus. People can have just cutaneous lupus on its own, and it doesn't mean that they're going to have any of the other manifestations. But I do keep a watchful eye, even if progression overall is a low percentage of people. They can have a positive ANA or a negative ANA. And there's a couple of different types. There's this annular type, and which is raised red lesions, and then the papillosquamous, and that looks a little bit more like psoriasis. Next slide. I've got a picture on those on the next one. So the annular type of lesion with that pink border that looks a little bit serpiginous with central clearing. Sometimes looks like eczema, and sometimes is mistaken for fungal rashes as well. And then on the right-hand side is a version that looks a little bit more psoriatic. But when these are scaly, that can also look very similar to psoriasis. Next slide, please. And then there's more chronic versions of cutaneous lupus. And this one, it's discoid lupus is the most common form. So that's what you're seeing here. And it can be difficult to treat. And one of the challenges of this is that it really can leave substantial scarring, hyperpigmentation, and can look like psoriasis as well with the amount of scarring. I actually like this picture in the right lower corner, better for sparing of the nasolabial folds, as you can see that more clearly in this picture. So because some of the follicles are involved, that's one of the reasons you can get hair loss. And you can get both reversible and irreversible alopecia, and then the changes in pigment are variable based on people's melanin distribution in their skin and the concentration of that. Next slide, please. And here's a couple more pictures of the discoid lupus, and you can see both the hypopigmentation, the scarring, and then hyperpigmentation. And these are significant rashes for people, and definitely a challenge for them. And I just want to call out DermNet. It's a source of all these pictures, and also kind of speaks to my heart because my mom's from New Zealand. So this is in Maori, and from some of these pictures are from Health New Zealand. So, next slide, please. And then just to show a person with more melanin, and you can see how they result in hypopigmentation. There's some hair regrowth around the central clearing spot, but the element of follicular involvement will probably lead to permanent scarring and alopecia in that central area. So next slide. Again, one of the tricks you can do sometimes, especially in skin with increased melanin, it's easier to see the color changes if it's on a blue background. And it's sometimes difficult to see. We show pictures where things are really pink and erythematous and more Caucasian skin. But in darker skin, sometimes lesions look darker brown or violaceous, or sometimes are just harder to see that contrast. And sometimes putting people against a blue background can be helpful. Next slide, please. So moving on to another case. Case 3, this is a 78-year-old woman who we saw as an inpatient. She developed a painful rash across her back over the course of several months, extending onto her arms, legs, torso, and face. She was very frustrated, in a lot of pain, quite miserable. And she had started hydralazine in the recent past for her blood pressure. And she'd stopped this and the rash hadn't gone away. Her sed rate and CRP were elevated. She had a pretty high ANA, and her C3 and C4 were low. She had a modestly elevated creatinine, and she had some proteinuria. Next slide, please. And this is an example of what her rash looked like. She had relatively large bullae distributed, especially across her back, her face, her arms. Very painful. These would rupture, almost like a burn in terms of level of pain. And so this is bullous lupus. Next slide, please, which is pretty rare. Um, and that was actually the only case I've really seen of that in the hospital. And it can be associated with hydralazine exposure, which is probably one of the more common medications that has some cutaneous findings for rheumatology. And um, and it can be also associated with systemic lupus, especially lupus nephritis. And she did have some mild kidney involvement. Um, and this is another scarring version, almost like a burn with the loss of that skin layer. And then these topical oral steroids, you can use hydroxychloroquine and dapsone. And she's actually doing much better. She recovered quite well. Sorry, I'm on call, so I'm gonna hold that on. But um, that brings up the issue of drug-induced rashes and findings on the skin that we see in rheumatology. And sometimes we help, and sometimes there's complications of our treatment. And one of these is hydroxychloroquine, which is one of our favorite and most extensively used medications. We use it for almost everybody who has lupus. We try to get them on this medication. Um, and it is an old medication initially used for malarial treatment. And one of the side effects that you can have that's not common, but I see it at least once every 5 years, I would say, um, is this hyperpigmentation. And this is a good picture I felt of the grayish color, and hopefully that's projecting well, that this can give people. I've seen it on people's face as well. And if even after the medication stopped, it takes quite a while for this to go away. And sometimes it doesn't resolve completely. I do send these folks to dermatology. Sometimes they do use some of the skin lighteners with some mild improvement. And I would say there's variation in how bothered patients are by this. If they feel they were really helped by hydroxychloroquine, I've had them not want to stop the drug because of this. And but I leave that choice kind of up to them. In general, I do recommend stopping the drug for this complication. Next slide, please. And then another couple of our medications that we use really frequently, like anti-TNFs, which are just game changers in rheumatology, and we use them extensively for lots of different types of arthritis and inflammatory conditions, including rheumatoid arthritis and psoriatic arthritis. And some of these are drugs like adalimumab or with the brand name Humira, and now there's at least about a dozen variations on that theme of the same drug with the biosimilars. But one of the things that it can do, paradoxically, it can cause psoriasis. So we use it to treat psoriasis and psoriatic arthritis, but occasionally it will also cause that. So that is the picture on the left. And then we do stop the medication for that. It can also cause drug-induced lupus and causes a positive ANA from time to time. And then on the right, this is a more common finding in general medicine, and it's a picture of shingles. But it's just a reminder that the JAK inhibitors, which are synthetic small molecules that are gaining in popularity, gaining indications all the time, we use these for rheumatoid arthritis and psoriatic arthritis, amongst other things, often more off-label uses. But they're important drugs. And unfortunately, one of the downsides and the biggest safety signal in the testing for these medications was the increased risk of shingles. And so we do strongly recommend shingles vaccination prior to starting or soon after starting these medications because of the risk for both disseminated zoster and for prolonged postherpetic neuralgia, which can be truly a frustration for patients. So next slide, please. All right, so moving right along to some psoriasis. So this picture is really of what nail pits look like. I've had learners ask me, well, what do nail pits look like? Because we don't see them every day. And one of the findings for psoriasis, and particularly people who have psoriatic arthritis, are changes in their nails. They get the nail can separate from the nail bed, which you can see at the bottom of this nail, and then those pits, and which are more likely for the person to have psoriatic arthritis if they have that finding. On the right is guttate psoriasis, which is this distribution across the back. They're smaller lesions. They're not the thick plaque-like lesions that we're always used to seeing. But again, it's another version of psoriasis. And next slide, please. And then this is a picture of the more common plaque-like psoriasis. So well demarcated, lots of scale, lots of hyperkeratosis. And these folks shed a lot of skin. Often they're very frustrated. It's painful, it's itching, and it can be quite extensive and problematic. And then the picture on the right is a less commonly recognized version of psoriasis that's sometimes mistaken, I think, for could be mistaken for morphea, which we'll talk a little bit about later, and then also for eczema. And this is flexural or inverse psoriasis. And when you think about eczema as occurring in kind of the creases of the skin, and this is at the chin level, and this can be in the axilla, even around the umbilicus and other areas. It's less plaque-like, and the distribution is just different, but also can be linked to psoriatic arthritis. Next slide. And then these are pictures of people with psoriatic arthritis. So it's about 30% of people with psoriasis will develop psoriatic arthritis. So it's not 100%. So every person who has joint pain with psoriasis doesn't necessarily have psoriatic arthritis. And then there's a smaller subset that even have rheumatoid arthritis rather than psoriatic. But these are examples of dactylitis, where you see them kind of massively swollen toes and fingers, often in this kind of ray-like distribution where there's two fingers that are swollen next to each other, and then it kind of skips a finger there. But this is a very painful and often a very destructive version of arthritis. There's multiple types, which kind of beyond the scope of this. But so if people have psoriasis, think about asking them questions about inflammatory arthritis in particular, and looking for things like this dactylitis, and looking for nail pets can be helpful. Next slide, please. So case 4. It's a 47-year-old woman with a worsening 3-month history of a facial rash that extends all the way down onto her chest, itching and burning. Again, photosensitivity, so worse in the sun. She's developed Raynaud's in the past year. Oral steroids helped, and she got a course, but her symptoms returned when she stopped the course of steroids. She does have a positive ANA at 1 to 320. Her sed rate and CRP are elevated, and CK and aldolase, which are both muscle tests, were normal. And she had a CT scan of the chest, abdomen, pelvis, and it showed a left ovarian mass. Next slide, please. And this is one presentation out of many for dermatomyositis. And as I mentioned earlier with lupus and the rash being in between the joints, here you see examples of Gottrins, which show the rash over, these can be kind of thickened and papular, as well as erythematous, and sometimes even have ulceration, and they tend to be over joints. You can also get them over extensor surfaces, commonly on knees, and sometimes even on hips, where it's called the holster sign if you have evidence of dermatomyositis on the hips. And I just wanted to call out that sometimes these can be thickened and ulcerated, and so we have an extensive panel that we can run for for these to look for antibody associations. And the antibody associations can be really helpful for kind of determining the phenotype that we're going to follow over time. You can often diagnose this MDA5, which is a pretty severe version and can be associated with interstitial lung disease. So if you see someone with this kind of ulcerated picture on the bottom picture, and they have a cough, that's somebody you would want to check out really quickly. And these can be a little bit difficult to treat, but determining the antibody profile can be helpful because then that will associate with a particular phenotype, and it lets us know a little bit about prognosis and what things we should be especially careful about screening for. Next slide, please. This is another typical picture with this mantle or shawl distribution, like the patient in the case, sometimes also distributed onto the back as well. And one of the features, you know, even though we call it dermatomyositis, people don't necessarily have the myositis part. So, and we call that amyopathic. And so their muscle enzymes can be normal. They occasionally can progress to a myopathic version, but that doesn't rule it out with having this normal CK and aldolase. And we really do have to screen for malignancy in dermatomyositis in particular, particularly within the first 3 years of diagnosis is when the risk is the highest. And we don't want to miss that because it's really, well, important to treat the malignancy, but it's also probably driving some of these findings. So next slide. And then this is another common presentation, and it's called heliotrope, which is a color purple version of purple. So people who are presenting with rashes on the eyelids definitely deserve our attention, and to be thinking about other things that can be associated with it. And we have lots of things that treat this. Often steroids, hydroxychloroquine can be really helpful in some of these settings. Sometimes we'll use IVIG and other more advanced medications. And then this one is people will come in with peeling hands and that are very frustrating. They've used all the creams, nothing is changing it. They may or may not have had a cough associated with this. Sometimes peeling around the nails as well. And this is a finding in a version of usually polymyositis, and we call it an anti-synthetase syndrome. Sometimes these folks will have fevers and as well. And this version of skin problem can be associated with interstitial lung disease. So again, important to think about tying those symptoms together if you see a finding like this. And I think it can look a lot like eczema and just topical dermatitis as well. So just things to keep on an open differential. All right, so thick skin. We're not all trying to get thick skinned. Here, probably the most common process that people will talk about is scleroderma. And so these are both pictures of patients with scleroderma. On the left side of the screen is an example of sclerodactyly, which I think sometimes it's hard in a picture because it's a sensory experience to really feel what that thickened and tough skin. They call it hidebound. So the skin can become very tight. And when we're looking at skin, often we're pinching people to see, does it tent normally in different areas to see how extensive the skin changes can be. And sclerodactyly can make it very hard for people to use their hands. It's shiny and very tight, and initially can be puffy, but then sometimes progresses to this thinner, tighter version. And then on the right-hand side, you can see findings of telangiectasias and the visible blood vessels. and difficulty with opening the mouth as there's progression of the fibrosis of the skin with scleroderma. And this can lead to a lot of difficulties, sometimes with just chewing and eating. And that can be complicated by the GI manifestations in scleroderma as well. And those telangiectasias are also a signal. People can have them on their hands, on the face, even inside the mouth. And a high burden of telangiectasias are associated with increased risk of pulmonary hypertension in this setting. So it's important to get those folks. You can check an ANA for sure. Often they have a more specific pattern to their ANA, and this is one of the places where the pattern can be more useful. So either an anti-centromere or a nucleolar pattern are things to look out for, and are often more associated with scleroderma. And then we also have a secondary panel that we can run for these folks to help with phenotype as well. So, and we're often these folks are followed by both dermatology and rheumatology, amongst others. And really, you cannot have scleroderma without Raynaud's. It really is a very, very important feature of the disease. Painful, sometimes very difficult to manage, and can be quite dramatic. And you can see that how it's usually with a very clear cutoff of the color changes versus the whole hand being involved. And you can see some of these characteristic color changes. There's often erythema and blue or cyanosis, as well as the white color changes. Next slide, please. And some of these are visible to the naked eye. And one of the very helpful things that we can do, because Raynaud's can also be a familial or a what we call primary Raynaud's, where people have it and it's not related to a connective tissue disease. And one of the things rheumatologists tend to do is look at the blood vessels at the base of the nail bed. And sometimes you don't even need to look with an ophthalmoscope or a dermoscope, which is just providing some magnification. And you can see these changes with the naked eye. And some of those are pointed out, that there's some more visible blood vessels and that there's a little bit of hemorrhage there. And other findings, scleroderma, lupus, and myositis are frequently all have Raynaud's. Those are the big three when people come in with Raynaud's that we think about in those presentations. Next slide. And then what we're looking at close up are these dilated capillary loops, and there's different versions over time. And I have been surprised when I thought somebody probably had primary Raynaud's, and then I took a look at their capillaries and they had dilated capillary loops. It definitely got me to rethink some things. And on the upper left, I think Dr. Lattis had a really nice description of these. It's almost like a lineup. I think it was, instead of bobby pins. I like that description. But very regular, not very enlarged. And then on the right side is right upper, you start to see those dilations, and they can get quite disorganized. And then over time, you also get dropout. So there's even gaps between the dilated vessels. And then you get some kind of regrowth in these branching vessels that when you're looking with magnification. So case number 5. And this is a 46-year-old woman who I saw in clinic. And she had exposure to a resin when she was using that to craft like a epoxy resin. And so, and after using that, she started to get some skin thickening, predominantly across her abdomen, but it progressed to her limbs. And over the course of the year, it got to the point where she really could not bend her hands. The skin was hard and woody, and she had an eosinophilia, and she's had an MRI, which shows some involvement of not just the skin, but the fascia. So just deeper to the skin as well. And this is a case of eosinophilic fasciitis. And it can be associated with exposures that people have, and just resins are one of them. And I think I'm also a preventive medicine person, so and we do more environmental histories, and I think that that's really valuable here in West Virginia because people do have exposures often through work, or even in their just life doing things that are fun. Um, and it can often be helpful in the setting of rheumatologic disease. And eosinophilic fasciitis, it's skin thickening. It is different in the way it presents from scleroderma. It's a deeper level of thickening, and that's why you get this groove sign. And you can see it often on people's arms, in particular, where there's along a blood vessel, it'll be kind of a dip, instead of it being smooth. And then the skin can also be kind of rough, looking this like an orange peel prodromal appearance. And there is overlap with this with morphia in certain populations. And I think that patient that we saw in clinic, that Erica picked up on actually, was also had morphia. So, and morphia is a skin limited version of scleroderma, often linear. It's not usually associated with systemic disease. It's often seen in kids. And but it can be extensive, and that was the part that looked more like the eosinophilic fasciitis, more like this generalized morphia, and you can get these pretty long scar-like lesions on the legs there. And then I think the bottom photograph here, to me, that can also be mistaken for inverse psoriasis. I think that, and that's why it's interesting to think about the distribution, because that's probably not going to be in a flexural area. Um, and it's kind of got this thin cigarette papery look to it, and they can be quite itchy. And I've seen those on the abdomen of patients, and I have seen them in patients with scleroderma, systemic disease too, but it can exist all on its own. So, next slide. And then vasculitis. So this is case 6. This is a 68-year-old man presented with painful ulcerating lesions on the lower legs, malaise, fever, and shortness of breath. So he's sick, and he's been sick for a while. He's had several bouts of pneumonia over the past year, treated with multiple courses of antibiotics, and he'd get better, but not really ever resolve. And then he developed a foot drop on the right side, and we checked antibodies for ANCA vasculitis, c-ANCA, and an anti-PR3 antibody, and those were both positive. So next slide, please. And so people who have what we call GPA, was what that diagnosis would be, granulomatous with a polyangiitis. And I know we've had a whole talk already on vasculitis. And, so we think of small to medium vessel vasculitis that shows up on the skin most frequently. And GPA is one of those types of vasculitis. Also tends to have lung involvement, was formerly called Wegener's vasculitis, but we don't use that term anymore. And there's multiple different rheumatic diseases that can cause vasculitis. Actually, my 1 o'clock patient has this finding apparently. And people can have leukocytoclastic vasculitis, and there are idiopathic forms of this. I do like to send them to derm first. I wouldn't say derm biopsies them 100% of the time, but it can sometimes be helpful. The person on the left has another version of palpable purpura that can be associated with IgA and deposition, which is a little bit different from other diseases that we have. So sometimes it's good to tell that. And that was used to be called Henoch-Schönlein purpura, or HSP. Also kind of a common version in children to see. So this finding, we're happy to see folks who have leukocytoclastic vasculitis or evidence of this purpuric lesions. So these are non-blanching distributed lesions. They can lead to ulcerations. You can see in those confluent areas, often there's skin breakdown because there's inflammation of the blood vessels and some localized clotting and just decreased blood supply to the skin. So you can get these areas of necrosis, and they can be very painful and slow to heal, and sometimes require systemic therapy and just a further workup to make sure we can understand what's driving it. It can also be malignancy or infection, other drivers. So not 100% rheumatologic disease, but we see these pretty frequently and can often help get them healed over time. The foot drop is also common in this GPA picture, and we do treat that definitely with systemic therapies like rituximab. So next slide, please. And then Vexus, I know this is some overlap with some of the Dr. Redmond's talks, and he was at the NIH when they did this work, which is really fascinating on Vexus syndrome. And it's really an abbreviation for vacuoles, E1 enzyme, X-linked autoinflammatory somatic mutation. And this is an acquired somatic mutation, predominantly in men because it's X-linked, although there are isolated cases in women. And initially, it was mostly associated with the ear findings, like this polychondritis and inflammation of the cartilaginous part of the ear. But as they've now been looking and finding all these cases, because we can do the genetic testing and people are looking at it retrospectively, that really one of the primary findings are these kind of plaque-like vasculitic rashes of the skin is probably more common than the polychondritis. And this is more common than lupus. So, and we've probably seen it, but we didn't know it. The knowledge around this really started to come out in about 2020. So we probably have patients that we have not diagnosed this in. And, but another important thing, so the median age is about 50, and predominantly men, rashes like this, lots of inflammation. So, and multiple systems, eyes, lung, renal, skin. But another important one that the skin can be a clue to what's going on. And next slide. Inflammatory arthritis, getting towards the end here. Had to throw in something for gout. And because tophi could be really helpful for diagnosis if people are having intermittent flares or acute monoarthritis. Tophi tends to be pretty late because it's the aggregation of the uric acid crystals, and they're notable for both the distribution. The ones on the ear are classic, and then there's creamy yellow to orange collections. And next slide. And this is the last slide. And reactive arthritis. This, to me, is a mimic of psoriasis, but it is keratoderma bleneragica, and it goes along with reactive arthritis. So people who have had an infection and then develop usually lower extremity predominant polyarthritis. And then they get this kind of classic rash on their feet. We don't talk about it very often, but easy to mistake for psoriasis and sometimes syphilis, which is unfortunately having a resurgence. So we might be seeing more of it. But that's it, the whirlwind of rheumatologic findings and dermatology.